All right, guys, so we're doing Chapter 10, Nutrition. We're just going to get started right here. I've got my whole book outlined on things that I feel were important throughout this chapter. So I've taken the PowerPoints that the publisher provided. They've outlined things for you, but I'm going to actually talk with it. So under Nutrition, right on page 130, talks about that of the top 10 leading causes of death in the United States, a lifetime of good nutrition would positively improve the 9 of the causes. So heart disease, cancer, stroke, chronic respiratory, Alzheimer's, diabetes, influenza, pneumonia, nephritic syndrome, nephritis, and septicemia. It also then talks about pretty much all elders, 87%, have diabetes, hypertension, high cholesterol, combinations of those diseases. So the book then goes on to talk more about how proper nutrition done over a lifetime can actually decrease all of these things from happening to people when they grow older. So that was kind of what that first little part talked about. The U.S. Dietary Guidelines. We're going to talk about my plate in just a minute. I know you guys actually already read this when we did it in class, but again, I'm going over it with some of the stuff that I picked out. So your book in this part talks about the guidelines on balancing calories with physical activity, because with this, I believe that the statistic, let me look, I think it's 50% don't hit like the amount of fruits and vegetables and all of that stuff that they're supposed to get. When we get there, I'll read it out of the book again. But anyway, so encourage Americans to consume healthy foods such as vegetables, fruits, whole grains, fat-free and low-fat dairy products, and seafood. Urge them to consume less sodium, saturated and trans fats, added sugars, and refined grains. And, all we have to do is look, like if you just Google and research a little bit of how other countries, developed countries eat, places like Britain, Australia, some of your developed Asian countries, nobody eats like us, and nobody has the amount of processed stuff that we have. It's actually very difficult now in America to be able to eat in a way that people used to eat prior to, and a lot of that goes into us not having the time because we're so busy. And then when we get to the older adult, we're going to talk about this in a little bit as well. The access, we talked about transportation the other day, the access to foods, and then, the income, being on the limited income, and then being lonely because food is so associated with sitting down and having a meal with other people. So many times. So here's the My Plate, and that's right from your guys' book on page 132. Really quick before I move into obesity, though, just to point out on the My Plate for older adults, it's a little bit different. You'll see that they actually make the one for older adults, which calls attention to the unique nutritional and physical activity needs associated with advancing years. And then the different things that are listed on there. This plan consists of fruits, vegetables, whole grains, low-fat dairy products, poultry, and fish, as well as a restricted salt intake. And then on 131, right before you get to other dietary recommendations, it actually talks about the Mediterranean diet, which, I'd heard some stuff about that and how they're looking at it. And it's obviously because your book is also discussing it, talking about the recent studies that showed the Mediterranean diet was very helpful in improving health outcomes. So just something for us to note. And then the rest of this here goes over the fat, the fiber, the vitamins and minerals. Basically, it just talks about how then with fats, we need to have a lower recommendation of fats, and that the book says that olive oil is the best kind of fats because of they lower the LDLs. And then your protein, it basically talks about how older adults are not getting the amount of protein that they need. Fiber is also not taken in as well, but that it needs to be taken with lots of water. Another problem that our older population has getting enough of, because the fiber will contribute to constipation if there's not enough water to go with it. So anyway, I think that was all that I wanted to talk about with that. I did highlight in the vitamin B12 deficiency that's common and under-recognized in 12 to 14% of older adults. And so that's going to be another thing with our screening with our B vitamins and all of that. Then you'll also see it talks about some medications that can impair the vitamin absorption. So, and those are listed right in there. And one of them that are listed is the proton pump inhibitors. So we learned about that in Farm, and a lot of people are on proton pump inhibitors. So we could actually have a lot of people out there with these vitamin deficiencies due to these medications that we don't even realize. So your next part here is obesity. This is such a huge number. The number of obese adults worldwide is 300 million, with estimates that 115 million people in developing countries suffer from obesity-related problems. So 300 million people, and we have 115 of those that are having health problems because of it. It talks about overweight and obesity are associated with increased healthcare costs, functional impairments, disability, chronic disease, and nursing home admission for our older adults. And then there's a statistic in here, since 2008, Americans aged 65 and older have seen the sharpest rise in obesity, and the proportion of older adults who are obese has doubled in the past 30 years. A little bit later here in the chapter, it talks about, again, the access to food and the access to money and the not wanting to, cook a meal for one. I know Elgina brought that up in class the other day. That would be hard to do. And the amount of eating out, eating at fast food restaurants. So many of these things can be contributing to that problem. And so, again, this is actually where I read the whole maintaining a healthy weight throughout life can prevent many illnesses and functional limitations as a person grows older. So if we keep it balanced throughout the whole life when we get older, then this may not be the issue that it currently is. So malnutrition is a recognized geriatric syndrome. That's the very first sentence that's in there. Malnutrition is a precursor to frailty and has serious consequences, including infections, pressure ulcers, anemia, hypotension, impaired cognition, hip fractures, prolonged hospital stays, institutionalization, and increased mortality and morbidity. And we actually talked about with pressure ulcers at one point in the class about why would somebody who's obese why is that not a risk factor? Because remember, if I have somebody who's got very bony prominences, they're at a much higher risk for pressure ulcers than that of a person who's overweight. So you'll see right under malnutrition, that is a consequence of malnutrition is the pressure ulcers. So characteristics of malnutrition, this is on page 134. It can occur when the individual does not consume sufficient amounts of micronutrients and macronutrients. So that's one way that it develops. And then there's a second way that it develops, which is inflammation-related malnutrition as a consequence of an injury, a surgery, or disease that triggers a state of inflammation. Inflammation is increasingly identified as an important underlying factor that increases risk for malnutrition and a contributing factor to the suboptimal responses to nutritional intervention and increased risk of mortality. Weight loss frequently occurs in both aspects of these different characteristics of malnutrition. So be aware that there's those two different types of malnutrition, that it can come from not getting in enough things, or it can actually come from the inflammatory mediators. Anyway, everything that I just read, anyhow. And so we're going to see weight loss with both things. With malnutrition, we're going to usually see weight loss with both of them. This right here just goes over the risk factors for undernutrition. This is right from your book on page 134. All right, so factors affecting fulfillment. This goes from 134 to 135. So they've listed them all out for you, and I've actually, let me see here. Let's see what's next here. All right, let's go back. I'm just going to kind of talk through this stuff right here. So lifelong eating habits, the only thing I grabbed out of there was individuals should be counseled to base their dietary decisions on valid research and consultation with primary care for providers. Because we have so much information out there right now on the internet and what other people tell our older adults and what they should do, that it's just best if we, encourage them to talk with their primary care about what their nutritional needs are. And then we have socialization. So this again goes into that whole part where food is used for, where we socialize during food. And so the presence of others during meals is a significant predictor of caloric intake. So they find that if you have other people around you to eat, you're going to eat better. And then it talks about alcohol in here. Misuse and abuse of alcohol are prevalent among older adults and are a growing public health concern. Excessive drinking interferes with nutrition. Drinking alcohol depletes the body of necessary nutrients and often replaces meals, thus making the individual susceptible to malnutrition. And so we know based on the things we've learned about addiction and alcoholism that, those patients are not nearly as well as others. And it's really important, especially for older adults, that we try to encourage them to limit their alcohol consumption because they really need to use those calories in a better way. But we know too that people drink because of depression, and if they're lonely and all that stuff, that pulls into there too. The next one is chronic diseases and conditions. We've actually already talked a ton about chronic diseases from our other chapter. I highlighted a couple things in there, but it was actually just repeat stuff, so just make sure you read through that. And then dysphagia, remember that's difficulty swallowing. It's a common problem from older adults. It can be a result of behavioral, sensory, or motor problems, and it's common with people with dementia. So an aspiration is a big risk on this one. Okay, so let's go through. We already did lifelong, we did socialization, we did chronic, all right, so now we're actually on assessment of dysphagia. So, let's see here. Well, again, let's actually just cover what we just were talking about. So, patients referred for dysphagia evaluation or a swallow study must be assumed to be dysphagic and at risk for aspiration. So they would be nothing by mouth, obviously, before having that done. There is symptoms of dysphagia or possible aspiration listed out for you on box 10.4 on page 136. And then I just highlighted that aspiration is the most profound and dangerous problem in older adults experiencing dysphagia. And then this was kind of cool. Your book talks about there's this neuromuscular electrical stimulation, and it has the FDA clearance now for treatment of dysphagia. The therapy involves the administration of small electrical impulses to swallowing muscles in the throat and used in combination with traditional swallowing exercises. So I actually thought that was pretty cool. So anyway, that's our assessment of dysphagia. There's your risk factors for dysphagia, our interventions for dysphagia that we can do. And again, you can kind of just read through these on your own right under interventions on there. I just read a couple of them for you. And then the other thing that I wanted to talk about, because I can't tell if it's going to be coming up here or not, nutrition, you know what, it's not. So the other thing that I highlighted is box 10.6. There's myths and facts about PEG tubes. And believe it or not, though none of it was super surprising to me, there are some misconceptions that I think I had too. So please read through those. It's good for us to have the myths and the facts about PEG tubes, so make sure that you go over those. And then there's the screening tools that the book talks about under, it's on page 139. So the first one it talks about is the mini nutritional assessment as a screening tool and a detailed assessment. It was developed over in Switzerland, and that is recommended by the Hartford Institute of Geriatric Nursing. And then if you look down, where's box 10.2? Actually, I think they listed the wrong one. But anyway, if you look down there below, I believe this is the right one. I'm not seeing it, actually, to be honest with you. And then the other one is the minimum data set, which we've talked a little bit about in the past, not a whole lot. But again, this other one is the assessment tool that's meant, they put the wrong number down there, I believe. So anyway, this is the one that you would want to kind of be just familiar with, because it's the one that the Hartford Institute of Geriatric Nursing has approved for nutritional screenings. So that's going to be the one that you want to do. There you go. There's another picture of it. And then our nutritional assessment. All of these things that are listed here, again, I'll kind of outline everything. And then, so the one thing that I pulled from it with the interview and the history is that they like to do that 3-day dietary record. And it's really important that, especially as nurses, that if we have a patient we're doing a 3-day diary on, that we make sure we monitor other people who are doing recording closely so we get the accurate stuff in there. And then you have your anthropomorphic measurements. That's just measuring, the different areas of the body. So like the triceps, the mid-arm, the skin fold thickness. And just at the bottom, I wanted to point out that if there is some kind of condition like hemiplasia following a stroke, the unaffected arm is the one that we're going to measure, not the affected arm. Let me look through here. BMI is to be calculated to determine if weight for height is within normal range. Remember, with older adults, it's 22 to 27. Next thing with our interventions NPO status and insufficient time for staff feedings will actually lead to adults not being able to eat. So your book talked about patients that are in nursing homes or in the hospitals, and that there's a major problem with there not being someone there to feed them because they're not able to feed themselves. So that was the last thing that I highlighted under there to pull out. And I've got 5 seconds, so that was it. And I will get on your next one in just a moment.